All right, everyone, welcome. My name is Dr. Ina Park. I'm the medical director and principal investigator of the California Prevention Training Center, and we bring to you several times a year this expert hour webinar series. And I am so delighted to have today our esteemed Professor Katherine Yang, aka Kathy, from the School of Pharmacy, who's going to be talking about HIV pre-exposure prophylaxis strategies. I have to go over a lot of housekeeping first, and then I'm going to dig into Kathy's bio and then leave it to her. But just a little bit about us, the California Prevention Training Center. Many of you who are on this webinar have been to our trainings before, but we are a multidisciplinary training and capacity building assistance center. We work in HIV capacity building as well as family planning training for family pack providers in the state of California. And then of course, sexually transmitted infection diagnosis and treatment. We are one of 8 centers in the United States funded by the CDC. And here are our sister sites all over the country. Just wanted to show you that map, and we cover the Western region as well as Hawaii. And I just also wanted to point out that if you have a difficult clinical consultation scenario, please send it to us via our online portal. It is a warm line. We have 2 faculty on call every day to answer questions at the stdccn.org. And I have to show you this legalese financial disclosure from our CME provider, the University of Nevada, Reno School of Medicine. And it's just talking about how all of our presenters do need to disclose any kinds of potential conflicts of interest. And so far, none of our presenters or myself have any conflicts of interest to disclose at this point. So the CME requirements are thus. So you register for this webinar, you have to watch it live and in full for CME credit. So you can, of course, if you can't make it to the program today and you're watching this recording, you certainly can, and you won't, however, be eligible for CME credit. So you also need to complete a post-course survey evaluation by January 25th, and you're going to receive a link within 24 hours after the webinar has ended. It's going to come from the nnptc@training.org. So if you want to add that email address to your safe or trusted senders list, if your quarantine filter is pretty strict, if you don't see the email notification in your inbox. So our CME provider, as I mentioned, is the University of California, Nevada, Reno. It takes about 4 to 6 weeks of processing time to receive your notification and be able to download your CME certificate. And you're going to get the notification to claim your link from UNR, And to make sure that you receive the email notification, please add our email address to your safe senders list, captc@ucsf.edu. This is the most important slide, other than Kathy's slides, of this recording, which is the post-webinar materials. When can I get the slides and the recording? So registered attendees are going to get these materials. We don't have handouts, but sometimes we do. And within 2 weeks after the webinar, you will get all of these materials. We actually go through the slides and we remediate them for compliance with the Americans with Disabilities Act, et cetera. And so again, add us to your safe senders so that you get these really important materials. So just an FYI, we are going to be having folks muted and the chat's going to be turned off, but the Q&A, which is down in the bar below, is the place where you can put in your questions. So please put in your questions and we will go over them in the 15 minutes at the end. And, again, we're not going to be answering questions live. We're just going to let Kathy speak. But, again, we'll collect everything in the Q&A box and I'll go over it at the end. And if you have any questions, sort of administrative questions about the CME process, please email Elizabeth Olson at elizabeth.olson@ucsf.edu. She is our program manager and can answer any of those questions. But again, just wait to make sure that you're going to get the evaluation, and then you will get your materials, and in 4 to 6 weeks, you'll get your CME. But now I get the pleasure of introducing Dr. Kathy Yang. She is a health sciences clinical professor in the Department of Clinical Pharmacy at UCSF and an infectious disease clinical pharmacist in the UCSF Medical Center. And she is like my phone a friend, infectious disease pharmacist whenever I have a problem. She actually specializes in the treatment of multi-drug resistant gram-negative infections and her research interest focuses on the pharmacokinetic and pharmacodynamic optimization of antibiotic dosing for the treatment of infectious diseases. And she happens to be a PreP guru, which is why I have her here today. So Kathy, excuse me, let me go back. I'm going to stop sharing. And I'm going to have you share, Kathy, and take it away.
Thank you, Dr. Park. Okay, so let's get started. And thank you so much for having me here. I love talking about PK/PD. I know it feels a little geeky to some, but it really drives everything that we do in terms of dosing in infectious diseases. So our objectives today are going to basically review the pharmacokinetic and pharmacodynamic differences and the properties between the different agents, including emtricitabine, tenofovir, disoproxil, the tenofovir alafenamide, and then the new agent on the block, that's cabotegravir. We're going to identify PK appropriate for daily versus event-driven PreP, review the side effects of PreP, and potential strategies for management, and describe the role of adherence in terms of PreP effectiveness. I don't have any financial disclosures. So the agents we're going to talk about today, these are the three. So we have the tenofovir disoproxil emtricitabine, that's the Truvada, that's the one that came out first. That was approved for PreP in 2012. And of course, then in 2019, we had the newer formulation, which is the SCOBY, and that's the emtricitabine tenofovir alafenamide. And that is also made by Gilead. And then very exciting, last year, in late 2021, Epitude, or cabotegravir LA, was approved, FDA approved for PreP as well. And that's the only one that is the long-acting injectable formulation. That one's very exciting. So before we dive into the pharmacology, I just wanted to briefly go over basically who is indicated for PreP and what do the new CDC guidelines tell us. And basically, is PreP right for me? Basically, we are saying everybody, it's right for everybody. So any sexually active adult or adolescent should at least be informed about PreP, and it should be offered for anybody who is at risk. And so that can be anyone who has anal or vaginal sex, any persons who inject drugs, or anybody who's been prescribed PEP or prophylaxis, post-exposure prophylaxis in the past. So any person that essentially you feel is at risk for STIs or for HIV. And so it's basically everybody at this point. And so the new guidelines that came out in the end of 2021, there were some key updates from the old guidelines. And again, basically inform all sexually active adults and adolescents about PreP. We had always known that we could use Ftdf for men or women, and that's the tenofovir disoproxil formulation. There was the addition of Ftaf for men who have sex with men or transgender women based on newer studies with the SCOBY. There's mention of the 211 or on-demand dosing as an alternative for men who have sex with men or transgender women, only with the Ftdf formulation. And of course, the new player is cabotegravir IM for men or women. So before we get started diving into the pharmacology, I just thought I would do a quick sort of primer on what is the difference between pharmacokinetics versus pharmacodynamics. And so pharmacokinetics, which you see at the top, is basically what the body does to the drug. How does the body process the drug? Where does it go? How is it absorbed? How is it distributed? How is it metabolized? And then how does your body get rid of it? So that is the ADME, absorption, distribution, metabolism, and elimination. So that is the key for every drug. That is how your body handles it. And different people will handle the drug differently depending on their individual, individual characteristics. And so ADME gives you what is this concentration profile that you will see on the right-hand side. So you take a dose, you get a concentration, a peak concentration at the top, and then eventually an elimination phase where your body gets rid of it. And this curve, concentration time curve, gives you a drug exposure. So that's pharmacokinetics. So what is pharmacodynamics? So pharmacodynamics is basically what the drug does to the body. So you take the drug and what is the actual clinical effect? So if we're talking about something like cholesterol, that pharmacodynamic effect could be something like lowering of your LDLs, increasing your HDLs. If you're diabetic, it could be the effect on blood sugar. So you have what is called this concentration effect curve. So with increasing concentration, you get an increase in effect. So for infectious diseases, though, we don't tend to look at pharmacodynamics as what it does to the body, but more in terms of what it does to the microorganism. So if we're talking about something like a bacteria, the pharmacodynamic effect would be the concentration of antibiotic you would need to kill a certain concentration of bacteria. From an HIV standpoint, that would be looking at, say, viral load. So what happens when we take a pill? So what I have here is actually a pharmacokinetic curve with oral dosing. So you can see that with each dose, you get this sort of up and down bump in concentration. And eventually, at some point, you get sort of a flat average steady state concentration, and that's represented by this line. So the time to hit this concentration, this average concentration, is about 4 half-lives. And so that is the time where you actually get to a concentration where you're not quite at like a steady concentration, but the peaks and troughs between the doses becomes less. So that time to steady state is actually independent of the dose. So it doesn't matter if you're taking, say, 200 milligrams or 300 milligrams. The time to get there is the same. It's going to be 4 half-lives. But what we do to optimize this is we will often load a patient with a loading dose, meaning giving a big dose at the beginning, and that gets us over to this average steady state concentration faster. So this is sort of the rationale you will see between things like 2-on-1 dosing, where you give 2 doses up front at the top, at the beginning to increase concentrations. And it's also the reason why for cabotegravir, you have the 2 injections up front, 1 month apart before you go to the continuation phase. It's to really get you to this higher concentration sooner, instead of having to wait for 4 half-lives. And so the idea then is to get you over this, get you to these higher concentrations and over the EC90 faster. So that's basically what happens when we take a pill or when you get the loading doses. So how much drug do we actually need to take for it to be effective? And that answer really is, it depends. So there are a lot of factors that come into play, and some of these are listed here. So how do we take it? Is it an IV injection? Is it an IM injection? Is it oral? And when we look at those different routes of administration, they have different absorption phases. So that will mean it gets to your site of action faster or slower. Where does it need to go? Some drugs have great distribution to all body parts and some not so much. So it depends where, for instance, the site of infection is. So if, for instance, if you were treating someone who had a brain infection, you would want to make sure that your antibiotic actually got to the brain. And so similarly for HIV, you want to make sure you target all your HIV reservoirs. How fast do you need it to get there, and where does it need to go? So if you're in a critical situation, like in the emergency department, or you had a septic patient, of course, IV is the fastest way. It's straight into blood and it has an instantaneous absorption. But for most chronic diseases, of course, we don't need to do that. We can just take chronic oral therapy and assume the steady state is about constant if you take the drug consistently. What is the drug's active form? A lot of these drugs have prodrug formulations, which we'll talk about, which means it needs to be converted into the body to the active moiety. And of course, we have patient-specific factors: fat, muscle mass, sex, kidney function, liver function. All of these are factors that play into how much drug gets into the body and where does it go. And of course, we have to factor in toxicity. So giving more isn't necessarily better. So at some point, we're going to start killing off the person. So we would have to have some type of maximum concentration. So this is a schematic of early HIV infection. And I show this because this just is a representative of all the main sites of HIV infection and the reservoirs that we need to hit. So places like PBMCs, the vaginal cervical tissue, and also rectal tissue. So these represent sites of infection as well as portals of entry. So how fast do we need to get there? And is the drug in its active form are important for each of these individual sites. So now we're going to talk about the two oral agents, and that are, of course, Truvada and Descovy. So before we talk about them, we just need to go over a little bit more pharmacology on the difference between these two agents. So Tdf is the tenofovir disoproxil fumarate. That's the formulation that is in Truvada. And then you have TAF, which is the tenofovir alafenamide, which is the formulation that is in Descovy. And so from this picture, you can see that we have the GI tract here on the left, and the active drug is actually tenofovir, TFV. So the interesting thing about this drug is TFV on its own has very, very poor oral absorption and membrane permeability. So, which is the reason why we don't take it, because it can't get into the blood. So because of that, we have these two formulations that are actually prodrugs. So the Tdf formulation has this ester moiety, and the TAF formulation has this amidate moiety on the side. And these two prodrug formulations allow the drug to be more orally absorbed and to increase permeability across the membrane. Now, the difference between these two drugs is Tdf has actually a very, very short plasma half-life and ends up turning into tenofovir at high levels in the plasma, which isn't necessarily where you want it to go, right? So you want it to be inside the lymphocytes or inside the PBMCs. So you get this high concentration in plasma, which then has to be pushed into the lymphocytes and then changed into the active diphosphate form to inhibit viral replication. TAF, on the other hand, has very low levels of TFE, tenofovir in plasma, has a much longer half-life, and is actually pushed into the cells at a much higher rate than tenofovir, disoproxil. And that has a lot of advantages in terms of getting higher concentrations on target in the lymphocyte where you want it to go, as well as having less concentrations off target, which cause toxicity. So tenofovir here, as you can see, in high concentrations from the Tdf, will actually be pushed into the renal tubular cells through this OAT transporter. And it's this pushing into the cells that leads to some of the renal toxicity you see, such as increased creatinine or electrolyte disturbances or Fanconi syndrome. TAF, on the other hand, has very, very low concentrations in plasma itself and is actually not a substrate of this transporter, which means it will not preferentially push into the renal tubules as much, which is part of the reason why you see less toxicity as associated with TAF. So the good news is TAF gives you more on-target concentrations and less off-target concentrations. So where does the drug need to go? And this is a graph just looking at the pharmacokinetics of tenofovir, looking at the diphosphate, which is the concentration you want, the active moiety that you want, looking at different tissue compartments. So you can see tenofovir, which is the one that we were talking about earlier that didn't have great solubility, concentrations pushing into blood. You can see that there is a differential in terms of how much is in colorectal tissue versus plasma versus the female genital tract. And the nice thing is the diphosphate version actually does have higher levels in the female genital tract, but you can see that overall the female genital tract is lower compared to colorectal tissue and PBMCs. And this is something you're going to see sort of consistent through all formulations as well as all studies. But this is part of what sort of defines how we dose the drugs and who we can use it in. So what does this mean in terms of time to protection? So if you look at daily TDF dosing, you can see that the time to getting high enough levels in PBMCs is about 7 days. In rectal tissue, it's about 7 days as well. But in female genital tract tissue, you can see actually down here, it's pretty low, even up to 11 days. So you don't really get great levels until about 20 days out. And this is part of the reason why the time to protection and how long it takes you to take drug before you get protection is different between males and females. So what about daily TAF? And that is a great question because all of these studies to date so far have been done with TDF. So we don't really know yet with TAF, and that is sort of an area of investigation. So this is the anchor study that looked at FTAF versus FTDF in preventing HIV infection in men who have sex with men and transgender women. And this is just the top line data that was shown in Lancet. I just wanted to show you here that in this case, you can see that the HIV incidence rate for both of these formulations was very, very low. But when you look from the actual data, you can see that FTAF was better and did show non-inferiority. But in general, they were fairly consistent across the two. So you're talking about incident rates of 0.16 versus 0.34 per 100 person years. So very, very low in general, which is awesome. So then looking at PK differences in the Discover trial, though, we can see looking at this data, which is model data, what the concentrations were with each of the different formulations. So the CTR here is the trough concentration of the active moiety of tenofovir diphosphate in PBMCs at 4 weeks using dried blood spots. And you can see that that for TDF, it's much lower than it is for TAF. So it's 61 F moles per 10 to the 6 cells compared to 404. Looking at the number of participants who had concentrations above the EC90, which is what you want, right? You want to have concentrations above this target. You can see also that TAF was much better than that. And the mean duration of protection was also longer with TAF than it was with TDF. So this sort of explains actually why there is a little bit of forgiveness with the daily dosing of TDF in terms of how many doses that you can miss in a week, because this half-life is actually, or this duration of protection actually quite long. So especially with TDF, which is the data that we have the most of so far, we know that we can miss a couple doses on the daily schedule and still be okay. And this is the reason why. So the big question then, of course, is what about women? So the data with Discover was with transgender women and men who have sex with men. Unfortunately, we don't have such great data with women. And this is basically consistent across all studies, is that we know that mucosal tissue in vaginal tissue, cervical tissue, and rectal tissue is much lower in women compared to men. So you can see here at 4 hours, there was 0% patients with levels below the lower limit of quantification with TAF compared to Ftdf, but still it wasn't great. So these are very small numbers. We can see that it was better with TAF than it was with TDF, but in general, they were low across the board. And so what does this mean clinically? What does this mean in terms of how do we dose? Can we use the same schedules for TAF and TDF in women? And the answer to that is really probably not, or we don't really know yet, because this PK data hasn't really reflected much in our clinical experience or in the clinical data yet. So looking at effectiveness of daily Ftdf versus Ftaf for PrEP by population, you can see that in men who have sex with men and in transgender women, it's pretty comparable across the board. We don't have any information on Ftaf for heterosexual women and men. And for persons who with injection drug use, it's even lower. It's about 74 to 84%. And we don't know with Ftaf at all. So this is based on the clinical data. And there's a lot of PK data that supports use for men, not so much yet in women. So that's basically sort of the unknown at this moment. So more to come on that. And safety, what's the issue? So there's been a lot of discussion of which one is better. Is it TDF? Is it TAF? Which one is safer? And we have to be careful in terms of how we interpret this data, because the differences in safety were really borne out looking at actually treatment for HIV using the high dose combinations with dolutegravir or with bictegravir. So this is data that doesn't necessarily translate over so well to PrEP therapy. And so in these studies, you can see that TDF did lead to decreased bone mineral density and increased renal toxicity. And TAF also did lead to increase in metabolic effects, such as weight gain, increased lipids, cardiovascular risk, and diabetes. But that's for treatment. So what about for PrEP? And so we have that data from the Discover trial looking at TDF versus TAF. And this is really interesting data, because when you look at these graphs sort of off the cuff, you can see that looking at bone marrow density, that there is a statistically significant difference between TDF and TAF. So you can see here that TDF has a decrease in 0.99% compared to increase in 0.18 for TAF, and this is statistically significant. But when we look at this mean percent change, what we are really looking at is really only a 1% change. So even though it is statistically significant, it is not likely to be very clinically relevant at all. And that's the same with the spine bone marrow density as well. And that pretty much holds true with the renal function assessments as well. So if you look at creatinine clearance, which is here on the right-hand side, you can see that the difference in creatinine clearance is only 2 mils per minute, and that's basically negligible. And it is statistically significant, but clinically insignificant at all. And then you can see here that the serum creatinine is actually the same for both. So it's interesting because this is represented in micromoles per liter, which is not a measure that I am used to. So when I converted this over, this gives you a serum creatinine of about 0.94 milligrams per deciliter, which is a number I think that we're more familiar with in the United States. So again, statistically significant numbers, but not likely to be clinically significant. And then down here, I just added a couple other measures because they're important from a patient counseling perspective, and also because they were seen in the original HIV trials, that the difference in the median fasting LDL you can see is 6.5 for TDF compared to 1 for TAF. But again, it's very small numbers, and you can get a slight increase in weight gain with TAF. So what is the take-home message? The recommendation, of course, still is to pay some attention to the renal function and to dose accordingly, so that if you have a creatinine clearance greater than 60, you can use either one of the agents, either tenofovir TDF or Ftdf, and they're okay either way for the right populations. And if you have patients with lower renal function creatinine clearance, then the recommendation is to use Ftdf. And so I just also added here for your information a quick link to a creatinine clearance calculator. So this is a question I get all the time, is how do I calculate it? And you can use this calculator to do your individual calculation for your patient. So all medication dosing for FDA is done based on Cockcroft and Gault, not EGFR. And so the reason I put this here is because sometimes there can be a little bit of a discordance between Cockcroft and Gault versus the EGFR calculation. And here is the basic formula for anybody who is interested. For these types of calculation, Cockcroft and Gault is sensitive to weight measures. So if you have a patient who is greater than 120% of their ideal body weight, it's better to use adjusted body weight for that calculation. Okay. And so what is the recommendation for the CDC guidelines? And this is basically what they are. So for men who have sex with men, basically daily or 2-1-1 with Ftdf or daily with Ftdf. For transgender women, it is daily Ftdf or daily Ftdf. For persons who inject drugs, daily TDF, and for receptor vaginal sex, it's the same. So unfortunately, we don't have a lot of good data yet with Ftdf. So that's why there is no recommendation as of yet for certain populations and for the 2-1-1 dosing. Hopefully we will soon. So with daily PreP then, how many days to protection? And it changes based on who you're treating. And this is based on the clinical data as well as the PK data. So in some of these situations, we don't have good clinical data to support it. So we only can go by what is in the PK data. And we know that the levels take longer to reach in women than they do in men. So that's why for receptive vaginal sex, the days to maximum protection is 21 days based on how long it takes to get levels in the female genital tract. And how long to stop? So for men who have sex with men, 28 days after last sex, same with receptive vaginal sex. And for NPEP, you can start anytime after 28 days with NPEP. Okay, so the next topic we're going to talk about is Epitude or cabotegravir, which, as we mentioned, was FDA approved in late last year. And there were two anchor studies that really got this, the PreP indication. And I have them here as just the top line data. The first one is HPTN 083. That's the HIV Prevention Trials Network Study 083. This one was done in cisgender men and transgender women only. And you can see from the top line data that the incident HIV infection for both was really, really low in general, but it was better for cabotegravir compared to TDF FTC, but in general was very low for both, 66% lower for cabotegravir compared to FTC oral, and there was good adherence for both populations. And I have just some top line data on adverse events here. We're going to dive into this in a little bit more detail. And then with 084, this was done in cisgender women. And you can see also that the cumulative HIV incidence was very, very low with cabotegravir, as well as TDF FTC. This data has been presented, but has not yet been published. And so women in the cabotegravir group had almost a 90% lower risk of HIV infection compared to the oral group. And this also is why the indication for cabotegravir includes both men and cisgender women. And you can just see down here that the HIV infections for both groups was very, very, very low in general, pooled incidence of only 1.03 per 100 person years. So very, very exciting. So a little bit more information on cabotegravir LA. So that's the Epitude. So as you know, this is given as 2 600 milligram IM injections 4 weeks apart for 2 doses. And that's sort of the induction or loading phase, similar to like if you were to load orally. And then you have the 600 milligrams IM every 8 weeks as the continuation phase. There is an option to do a 4-week oral lead-in versus just having a direct injection method. There isn't any real advantage for the oral lead-in in terms of efficacy. This is really for tolerability of side effects. So, you don't have to do it if you don't want to, and it may be something worth discussing with your patients. Some patients are very, very anxious about side effects, or they may be very prone to hypersensitivity reactions or nausea or any of those types of effects. This might be something that may be more reassuring to them, but it's not required for the actual antiretroviral effect. This is a 3 ml gluteal injection. So it's done, like I said, every 4 weeks for the first 2 doses, and then every 8 weeks. And how it's done is really dependent on how big the patient is. So if the patient has a BMI greater than 30, the recommendation is to use a longer needle at 2 inches. And if the BMI is less than 30, to use a shorter needle. And the reason being is because this is really a depot preparation. So it's going to depot into the large muscles. Because it is such a large volume, the PK is really not going to be very reliable if you do it in any other body space, like a deltoid muscle. Those are probably too small to depot this large a volume in, and it's not recommended that you use any other muscles. Also, in the original studies, patients who had gluteal fillers or implants were excluded, which makes sense because you don't want to accidentally inject this into, say, an implant or any type of silicone filler or implant or fat space like that, because we don't really know what the pharmacokinetics will look like if you go into those spaces. So the recommendation is really to do it only in the gluteal muscles, and to avoid patients who have these fillers or implants if you can. So because we've been talking about PK by site, this is what cabotegravir by site looks like. So with a 600 milligram IM injection, we can see that the highest levels are still going to be in plasma, and the lowest levels, not surprisingly, are still going to be in female genital fluid. And then rectal fluid is sort of in the middle here. And this top graph is based on exposure. So you can see here that the axis is AUC, or area under the curve. The bottom here, what I have is actually a table showing the individual PK curve parameters. And I found this to be really interesting because you can see that the Cmax, or the maximum concentration of cabotegravir, occurs in plasma at a concentration about 5, and then it is not so high in the other spaces, which also reflects in the top graph. The Tmax, which is important, the Tmax is the time to maximal concentration, is about a week across the board. And then the half-life, you can see, sort of has a range of about 2 to 3 weeks, depending on the body space. So based on this information, can we take a guess on the time to protection? And that's a really hard guess because we don't really know. We don't know what the actual threshold is in terms of how much drug you need to be effective. But we do know that within a month, we have fairly significant levels. So it's fair to say within a month, but hard to say sort of before that what it would be. And there's been a lot of discussion of this cabotegravir tail. So what the tail is basically after you finish your last injection, say if the patient wants to stop, how long does it take for the drug to go away? And so you have this half-life. This is model data based on HPTN 077, which was a phase 2 trial. And you can see here what's interesting is the half-life is much longer in women, so 60.4 days compared to men at 45 days. And the time to the lower limit of quantification is 67 days and 67 weeks, excuse me, and 43 weeks for male. So really long, up to a year. So that's something that is worth describing to your patients, because this long tail makes a difference in terms of both side effects as well as risks. And the other things that were found in the study was in addition to female sex, BMI was also associated with this longer tail, which makes sense because with a higher BMI, you have a more deep-going effect, and likely there's going to be a slower absorption elimination phase. And not surprisingly, the adverse events compared with the injection phase were much, much lower. So what does this mean? So the tail basically has a good news, bad news phenomenon. So the good news is we can use cabotegravir for patients who may not be the most adherent to therapy. So if you only have to do an injection every 2 months, that's great. It's well tolerated and there's no new adverse effects associated with the tail, which is what you would expect because levels are going down. The bad news is there is likely to be a risk of developing resistance if any patient develops HIV during this tail phase. The other part of this bad news is we don't really know when this protective threshold hits. So since we don't know what the level is that is required to be fully effective, we don't know what the level is that it would be ineffective. So a little bit of counseling on the unknown. And in terms of hypersensitivity sensitivity reactions, this is also something we always worry about when we give long-acting agents. So if you are having a hypersensitivity reaction, say a anaphylactic reaction or an anaphylactoid reaction, because of the long half-life, that hypersensitivity reaction can last quite a long time. So for patients who are concerned about that or who are prone to having drug reactions, this might be something where it's worthwhile to have that sort of 30-day oral trial before you move to the injection phase. Okay, so what do we do about missed doses and discontinuations? So I have here a few scenarios listed. And I will say that the way this is listed in the package insert is a little confusing to me. So I've tried to break it down for you as much as I can. So essentially, the first scenario is if you are plus or minus 7 days from the scheduled next dose, you can continue as normal. So you don't have to necessarily give it exactly at the 4-week or 8-week mark. You have a 7-day window on each side. So what happens if you miss a dose? So, or if you're late, and it makes a difference sort of whether or not you're in the initial 2-month induction phase versus you're in the continuation phase where you're getting it every other month. But essentially for both, the recommendation is if you are less than a month late from the last injection, you would just give it as normal and continue as scheduled. So for instance, if you got your first dose of drug and you're scheduled for your second dose and you miss your second dose, but you are within 2 months from your first dose, so you have a month as sort of the buffer, give it as normal continue as you normally would. And that's the same recommendation if you're in the continuation phase. So if you're supposed to get it every 2 months, but you get it, say, within the 3rd month, that's still okay, continue as normal. But what if you miss more than a month? And if you're more than a month late from your last injection, the recommendation is that you have to reload. So you start over with the 2 IM injections at 1 month apart and then continue as normal. If you have a planned interruption during your continuation phase, so during the every other month schedule, you can bridge that with oral cabotegravir until your next injection up to 2 months. So that makes sense. And if you discontinue PreP altogether, the recommendation is then to do oral daily PreP starting 2 months after the last dose. So here's just a few slides on adverse effects. So by far, the most common adverse effect is going to be injection site reactions. And interestingly, there is a sex difference here as well. So in 083, which is the men who have sex with men and women, the rate of injection site reaction was 82%, which is much higher than it was in women. The most common side effects were pain, tenderness, and swelling. And you can see from this graph on the right-hand side that those injection reactions typically started about a day after the injection and lasted for about 3 days. Okay, so the incidence and severity of those reactions go down with time. So with every subsequent injection, there were less and less, which is great news and a great counseling point for patients who are worried. You can always manage those with OTC analgesics and warm compresses. You can even pre-treat them with analgesics before OTC analgesics before they get their injection. And I just have down here on the right, just a graph to show you that even though there were injection site reactions, it was rare overall, and grade 3 reactions requiring discontinue are actually very, very rare, less than a few percentage of the total. And the other side effect that was most noticeable was weight gain. And so I just have a little bit of data here to show you that, again, there's a sex difference. So in 083, the overall weight gain was 1.30 kilograms per year. And for women, it was 0.42 kilograms. So not as much for women compared to men, but still something to pay attention to and something that you can counsel your patients on. And just lastly, a word about drug interactions. So unlike tenofovir, there is a drug interaction with cabotegravir and these enzymes called UGT1A1 or UDP glucuronol transferase enzymes. So these enzymes are located in the liver, the kidney, and intestines, and are basically responsible for detoxifying drugs in your body. So they do this process, this metabolic process called glucuronidation, which essentially inactivates the drug, increases the solubility, and then enhances reelimination. So the worry then is if you give this drug, cabotegravir, any drug that increases or induces GT function, the worry is that you can get actually increased drug elimination and lower cabotegravir concentrations. And if that's the case, the worry, of course, is that you will drop too low and lose your ability to prevent HIV. Again, we don't know what that threshold is. So the idea then is to just not start patients on any drugs that are known to be UGT inducers. And luckily, it's a very, very small list. And most of them are anticonvulsants, such as phenytoin, carbamazepine, which also happen to be CYP3A4 inducers, and rifampin, which is used often for HIV, or excuse me, for TB therapy. So what about adherence? So in the last few minutes, I just wanted to talk briefly about how adherence is measured and what that means for PreP therapy. So lots of different ways to measure adherence. Unfortunately, none of them totally clinically useful yet and not yet ready for prime time, but hopefully at some point we will have an objective measure for adherence. So how much adherence is good enough? And again, it changes between men and women and the tissue compartment we're looking at. So because of the PK information that we saw earlier, it looks like you can get away with actually only 2 doses a week and have good enough levels in rectal tissue, excuse me, that went on its own. But for female genital tract, you can see here that you actually do need to have pretty good adherence, almost 100%, to have levels that are high enough and over the EC90. So again, a sex difference. And this is just clinical data from the IPREX and Discover trial, just to show you how that translates into clinical outcomes. And essentially for both, the take-home messages, you really need to have more than 4 to 6 doses per week, regardless of the population. So adherence of greater than 4 doses per week showed that the HIV cases were very, very low, if not, not at all, compared to if there was doses less than 4 times a week. So that has really been sort of the cutoff or the tipping point, is about 4 doses per week, and it's been shown in multiple studies. So what about 211 PreP? And so this has been called on-demand PreP, event-driven, or even intermittent PreP. And so the idea with this is to take 2 PreP pills anywhere between 2 and 24 hours before sex. Closer to the 24-hour mark is better than 2 hours, because it gives you time to build up tissue concentrations. Then you have sex, and then you take 1 PreP pill for until 48 hours after the 4th dose. So this is a recommendation for men and cisgender men, and transgender men who have sex with men. So in this dosing regimen, how does that work then? So again, on the left-hand side, 2 doses 24 hours before sex, and then a dose 24 and 48 hours. But what if you have multiple sex episodes in a week? And so this schematic on the right-hand side just shows you how to manage that. So if there's multiple sex episodes, just continue taking the daily PreP as you normally would until 2 days after the last sex episode. So again, 48 hours after the last sex. If you have a break in sex, as long as the break is less than 7 days, you can just continue taking 1 a day. And that goes back to sort of the data that shows as long as you have at least 4 doses in per week, that the efficacy is higher. But if you miss more than 7 days since the last PreP dose, then the recommendation then is to start over. And so I just wanted to finish with a couple of slides on sort of some PreP use patterns. And you can see here, this is a study that I found really interesting in terms of switching between daily PreP and event-driven PreP. And so you can see here that in a 3-year period, at least 1/3 of all patients switched at least once. And the most common switch was actually to go from event-driven back to daily PreP. The median time from first switch was from daily to event-driven was about 1.1 year, but it was more common to go from event-driven over to daily. So lots of switching back and forth and a lot of movement. So a lot of counseling points that can be associated with that. And this is some really great data from Kaiser Northern California, looking at PreP services and characteristics of PreP use behaviors in their health system. And I just wanted to show you this because it really did show sort of where the gaps in care are. And so it showed that about 98% of people who were prescribed PreP actually took it. So you can see that here, which is great. Eventually, about 52% of patients DC'd their drug at least once during the study, and the highest rate of that was actually within this first 2 years. So if you're going to catch people who are going to be non-adherent or discontinue their PreP, those counseling, intensity really should occur in the first 2 years to keep people on therapy. And 60% or so of patients you can see here, actually restarted their PreP. And lastly, on this right-hand side, this is data which you would expect, but it's just a hazard ratio of who is most at risk for stopping therapy and who is most at risk, who is most likely to start therapy. And what you see here, of course, is women will be less likely to get a prescription, be started on it, but be twice as likely to stop therapy and half as likely to restart. And of course, these numbers are consistent across other populations you would think of, including Latinx and African American. So those, of course, are the populations that we need to target. And this is just showing how that translates to HIV incidence, as you can see here. And lastly, just a couple slides on continuum of care. So this is information looking at pharmacy claims. And so you can see here that just because the prescription is written doesn't mean the patient gets it. So of 91,588 patients who were prescribed oral therapy, 86% picked it up, 15% did not. And of the 15% that did not, 75% of the patients actually totally abandoned therapy within 90 days. There was, within a year, that number actually went even higher to 87.7%. And you can see here how that translated to HIV diagnosis. And lastly, I just thought I'd finish with one last slide, also to give a shout out to some of our wonderful Pharm.D students at UCSF who did a study looking at SB 159. And this is a California bill that was passed that allows California pharmacists to furnish PEP or PreP without a prescription in community pharmacies. So they basically called pharmacies within the San Francisco Bay Area to see who was offering this. And of course, this happened during the pandemic, so almost nobody offered it. But only about 2.9% of pharmacies in the SF Bay Area actually furnish PEP or PreP. There were no chain stores in this cohort, so basically independent pharmacies. And when asked about barriers for either PEP or PreP, they mentioned a lot of things that I think we have places to work on in terms of gaps of care. COVID-19 was huge. The ability to obtain labs, reimbursement, patients just unaware that they can even get PreP or PEP in a pharmacy, and difficulty connecting patients to follow-up care. And so I just wanted to finish with one last slide just to recap everything that we talked about of what we know versus what we don't know. Luckily, what we know is that intracellular levels predict efficacy, but we need a lot more data to see how that translates into clinical care. Daily PreP and 2-in-1 is an alternative for men who have sex with men or transgender women. And we definitely need good adherence. We need even better adherence for women. And the safety is pretty comparable between the two. Cabotegravir is very exciting, and it's going to be a great option for both men and women. What we don't know is the efficacy of 2-in-1 with TAF or in cisgender women, either the daily or 2-in-1, and how much is good enough. It seems like that we need to have a lot higher concentrations, but we do need additional studies to figure out what that is. And most importantly, how do we close the gap in the continuum of care? So just because we prescribe it doesn't necessarily mean the patient takes it, and how do we track these patients and make sure they stay on therapy? And with that, I thank you for your attention. I know that was a lot of information in a very short amount of time. So I'm happy to answer any questions.
Thank you, Kathy. Can you hear me?
Yep.
Oh, great. And I don't see myself, but I am here. I'm going to start going over the Q&A. And first of all, I think we're going to get t-shirts made that say PKPD is fun. That is such a great talk. I just love it. And this is actually the second time I've heard it, but more information on cabotegravir, which is very exciting. First question is from Kelly Johnson, who says, thank you so much, Kathy, for this talk, and is curious about injectable cab, not wanting to inject into fillers, because we know lots of our transgender women patients do have fillers or implants. And she's wondering, do you have similar concerns in people who are obese? And was there any BMI data from the HBTN trials that look into absorption in folks that are obese?
Yeah, that's a great question. Not so much data. And as long as it's in a tissue space in the gluteal muscle, I don't think it matters so much. You may have a little bit of slower absorption, but it shouldn't be that big a deal. These drugs have fairly high volumes of distribution, so it shouldn't matter as so much.
The next question from Tamara Ooms is, again, about transgender women for gluteal implants. For someone who couldn't take oral PreP, theoretically, could you divide the dose and inject it into another large muscle group like the quadricep? Obviously, that's off-label because it was studied in the gluteal muscle. Or, I'm just going to throw something else in there, like, a longer needle, spinal needle, or something like that to get to the gluteal muscle.
Right.
What are your thoughts?
Yeah. Good luck with a larger needle. That will be a hard sell. The PK of really outside of the gluteal muscle is really unknown. So I don't think that's a good idea until we have additional information on that in terms of both absorption and distribution. So the quadricep isn't quite the same, right? So as the gluteal muscle, I mean, it's a different muscle. There's going to be fat involved, different fat around the muscle. So I don't think we can make that leap yet.
Okay. Another attendee who didn't leave their name was asking, I think in the HBTN data that was looking at the adverse reactions between 083 and 084, between cisgender women and men and transgender women, there was such a huge difference in the groups in regards to adverse reaction. Any indication as to why?
Yeah, I was thinking about this, and I thought about making a snarky comment of just women are just so much more able to tolerate stuff than men. But I didn't want to make the snarky comment, which I just did. It's hard to know. I think remember 084 was done first, or 083, the men was done first. That was an earlier study.
Yeah.
So at that point, it was very unknown, what any type of these reactions were. So I think by the time you got to 084, there was probably more information, better counseling. I can't remember if they used a different placebo. I do remember they used the intralipid placebo for the 084, but I don't actually have a good answer of why it was so different between the men and women. Just outside of the fact that it was done first.
Right. And we have our other theories about people's tolerance for pain based on gender, but our sex differences. Javier Novarosa was asking, have you seen people start to roll out cabotegravir in any, maybe not in the setting that you're working in, or have you heard of other people rolling it out in other settings yet?
Yeah, so I know clinics are starting up. It's not cheap, remember, and there's a whole bunch of insurance things that need to be done, and specialty pharmacies that have been ordering it for administration. So because it just rolled out, in December, and it was the holidays, I haven't seen that many clinics doing it yet, if at all, but now is sort of the time to get that going.
And then a question, I hope I don't butcher her last name, Laurel Raffetsetter was asking, do you know which pharmacies offered PreP? And I think this is probably the community-based pharmacy model. Do you know which ones offered PreP in San Francisco? It would be great for them to refer their patients.
I don't have the list on me, but if you email me, I can probably get you that list based on the study that the students did. I think it actually would be great if at some point we could get some type of dashboard up on CDPH that shows sort of where you can go to get PEP and PreP, which pharmacies have it available.
You know what? So if you have so you're saying, Kathy, that you have a list from that study, because maybe we could send it out with the materials to the attendees.
Okay, I'll see if I can track that down.
for those who are referring patients in San Francisco.
And it was done, and remember that was done during COVID, and it was done sort of probably a couple months after the lockdown occurred.
Right.
So I'm sure actually that list is much larger. It would be great actually if, I'll see if I can figure out if we can get a list, a recent listing, because most, all pharmacists who do this have to do some type of training, right, in order to be able to dispense. So that's got to be logged somewhere. I wonder if we can find that list. That's a great question.
Yeah, so we'll follow up with you on that afterwards. And so Claire Morello was also asking, does a trial of oral cabotegravir, like reliably predict hypersensitivity to the injectable? And do you, like you personally, are you sort of more inclined to always have a trial of oral first?
So I think we should separate that between, hypersensitivity, which is more of a immunological phenomenon, right? Versus the most common side effect you're going to have with cabotegravir is going to be injection site reaction. So taking oral is going to tell you nothing about injection site reaction, right? Which is going to be the predominant thing that people are going to have to worry about. I don't think it's necessary unless you have, we do have certain patients who just seem to be allergic to everything. Yeah. And in those patients, I might do it. But for the general population, I don't think it's necessary.
Okay, that's helpful. I think this is our last question for now. Do you know anything about long-term side effects for cabotegravir?
Yeah, not yet. So the studies have only gone out for 3 or 4 years. So, long-term meaning longer than the studies, not yet.
Okay. Okay, and this is your, my final offer in terms of questions for Dr. Gang, but since we don't have any in the Q&A right now, I wanted to ask you, I don't know if you might need to go back to this slide, but in terms of the tail and covering the tail, Kathy, a counseling point for patients who want to go on long-acting CAB, to counsel them that they may need to take daily PreP for a pretty long time. And I'm just wondering, do you recommend that they take oral PreP to cover the entire duration of the tail? And so about how many weeks would that be again? I just wanted to double check.
Yeah, so covering the tail, that's a great question. So if you look at this, let me move the camera, is like right on top of my slide. I can't even see it. So hold on, I gotta just move, there you go. So you can see this tail is different between men and women. And so the only thing that we can say is if we're gonna cover the tail starting 2 months after you discontinue, which is when you would get your normal shot, sounds about right. But for how long you cover the tail, that's a good question, because you can have levels on average for up to a year. Right. So, but I also think it depends on what that person's going to be doing during that period. Whether if they're still at risk versus they're going to, what are they doing during that time? Sure. Yeah, so that's a good question. I don't necessarily, I think if you're going to cover the tail, we should be talking about, are we covering for PreP? Like, are we doing PreP? Like if the patient is still on PreP or still needs PreP, whether or not you cover the tail is sort of irrelevant, right? You just go on oral therapy. So that's kind of what I would say. If they still need PreP, they should just keep on taking it if it's oral, but starting 2 months after their last injection. It's just an issue with some patients who didn't want to take oral to begin with. And then you're telling them, hey, you really need to still be on PreP. So you're probably going to have to take oral to make sure you don't get HIV during this tail period. Right. Right. Exactly. Couple more questions, because we do have a few more minutes from Baby Ruth Gehring. If you're taking oral, PreP, how many days? Oh, and then a patient ran out of medication. How long can they sort of have a gap before restarting? And so, let's say a cisgender man or transgender woman versus a cisgender woman. Yeah. So, did I have a slide on that somewhere? Somewhere, I think. So, for women, it's really tough because it's very clear that you need to have good levels all the time. But for men, it's a little bit more forgiving, right? So you can miss up to 2 or 3 doses or so and still be okay within a week. But for women, it's a little less forgiving. So you probably do need to take it for a little bit longer than that. Where did that slide go? Let me see if I can find it.
Yeah.
I thought I had a slide somewhere. Yeah, this one, days of protection. So, you know, whether or not you need to take, I don't think you need to take 21 days again, but it clearly is, you do need to take it longer.
Okay. And then another question from Kelly Johnson. Any thoughts on why breakthrough infections for the HPTN 083, so that was the MSM and transgender women, did not occur during the tail?
Yeah, it's a good question. I think, you know, that's also in a clinical trial setting. I think we're going to have this in a very controlled setting. So once we see how this plays out in real life, I think we'll see more. We probably will see more once it becomes in real use. But that was such a controlled environment. It's hard to know.
Well, Kathy, I think that's our last question. Oh, sorry. Can a patient take Tdf PO if they missed their cabotegravir IM? And I do believe you talked about this.
So
no, you talked about taking cabotegravir PO. Can they actually can they take Tdf PO if they missed their cabotegravir injection? So
yeah, I wouldn't recommend doing that, because you'd also have to have a period to get your Tdf up to concentrations, right? So if you're talking about daily, it would take you 7 days to get there, or right? But if you were in, so it's a different, it's not like one drug when the other adds up together to be productive. It's one or the other.
All right, I'm letting the last question in from Jenny Scanlon, because I asked you this question the last time I heard this talk, Kathy, about, is anybody out there that you know of doing a 2-pill loading dose for Tdf to get protection earlier when starting daily? So it's almost like jump starting them with a P11.
Right. It's a great question, and it's not in any of the recommendations, but from the perspective of the how you do it, it totally makes sense, right? Yeah. So you're loading the patient and then you go. So I think it's, let's see.
Yeah, it's early, one of your early slides.
This one, right? So.
Yeah. Oh no, yeah, that one, yeah.
Right. So
yep.
It's essentially the same thing, since if you're doing 2 and then you're saying you can continue in this phase, just keep on taking it, you're essentially just loading the patient. Yeah. So I don't know, it's not a recommendation in the actual CDC guidance, but it makes sense.
Yeah. Okay. Okay, fine. Oh shoot, there's more questions and I can't do it. Oh, and someone says she's doing it in Denver. And Baby Ruth asks, is 2-1-1 CDC approved? It is. PreP 2-1-1 is discussed in the new PreP guidelines. And Annalise Monterosa was saying, could you take oral cabotegravir for PreP? And I don't think we have data on that, but yeah. Okay.
And you know, it's interesting because the CDC does, the CDC recommendations, you talk about the 2-1-1 PreP, but they don't put it up in their front page as.
No, right. They don't say we recommend this as a strategy necessarily.
Right. It's like a loosey-goosey thing. It's definitely a viable alternative, and I think we should do it. But it's funny that they don't put it up straight at the top.
Yeah. So Kathy, can you stop sharing for 1 second? Yep. And then I'm just going to put up the CME slide and thank everybody for coming. Oh,
sorry. There you go.
That's okay. I'm going to thank everyone for coming today and attending this webinar. And I'm just going to put our last slide up about the CME and show you that. Hold on. Let's see. I don't know if that's working. Can you see this slide at all or no? Hold on.
Oh, it's in the slide share view or the presenter, whatever view.
Okay, so, okay, now it's showing this. Never mind. I'm sorry. I'm not going to be figuring this. Oh, here we go. So you're going to be getting, again, an email about the post-course survey. Please complete that by January 25th. I want to thank everybody for attending. Thank you so much, Kathy. That was fabulous. And we're so happy to have you. Thanks everybody for attending, and we will see you next time for our next expert hour webinar series. Bye everyone.